She was standing at the end of the corridor
Where are you
when the
taking me?
security guards came for her.
Just cooperate.
Not running.
It's
not
for your
hiding.
safety.
Just standing there with her hands
doesn't
folded
feel
in front of
right.
her, a small laminated ID badge clipped to
What's
her chest.
happening? Why the
her white
police?
uniform
Ma'am,
perfectly
just
pressed
keep moving.
despite
It's
it being the
urgent.
41st hour
There's
of her
been an
shift.
incident.
The corridor
We need your
lights
help.
buzzed
What kind
overhead.
of incident?
That particular
explain inside.
hospital
Hurry.
hum that sounds like the
The
building
patient's
itself
condition is critical.
holding its
We need to
breath.
act now.
3 men,
Yes, doctor, we're
2 in
ready.
security uniforms.
Good.
One
Monitors
in a
vitals
suit.
every 15
The man in the
minutes.
suit
Understood.
had a
We'll report
folder
any
pressed
changes.
under his
Good.
arm like
Let's
a
move.
weapon. He walked the way
Look at this
people walk
waveform.
when they've
It's
already
irregular.
decided the verdict
What's the
before
reading?
reading the charges.
Heart rate's elevated and the rhythm
Administrator
is off.
Rourke.
We need to intervene.
Elaine Marsh.
Should I get the crash
We need you
cart?
to come with us.
Yes.
Now,
And page the doctor
the other
stat.
nurses in the
We need to
corridor
stabilize
froze.
him
Trey
now.
stopped moving.
Check
A
his
monitor
vitals. Get
beeped
the crash
3
cart.
times in the silence
Vitals are
between his
dropping,
words
doctor.
and her response.
Push the epi.
Someone's
I'm
floor
right
bag
here.
dripped. Once, twice,
Look,
3 times.
the manifest
She
matches
didn't
the warehouse
flinch.
logs.
That was the
Let me
thing
see.
nobody could
What's
explain
the connection
afterward.
to the suspect?
She didn't
The
flinch
shipping
even
routes.
a little.
They're on the monitor.
Dr. Callahan,
Overlaying now. It's a
chief of
direct link.
medicine,
Good. Lock it
appeared
down.
from around the corner. He was a man who wore his authority like a second coat, always buttoned, always visible. Behind him, 2 more men neither of the nurses had ever seen before. Clipboards. Badges. The kind of badges that don't have a hospital logo on them. Dr. Callahan. Miss Marsh, I'll be direct. Our inventory system flagged a significant discrepancy. Over 400 units of fentanyl patches. 60 vials of morphine sulfate. 3 months of documented shortages, and every single one traces back to your access card. The word fell on the corridor like a stone dropped into still water. Fentanyl. Everyone heard it. Everyone understood what it meant, not just medically, but legally, career-endingly, life-alteringly. Administrator Rourke opened the folder and held it out like evidence at a trial. There were printouts, access logs, her name on every page, timestamps from the middle of the night, the pharmacy lockup, the medication storage unit on Ward C, her badge, her code, her name. Rourke, we've already contacted the police. They're on their way. We're asking you to cooperate and surrender your ID badge. You're suspended pending investigation, and frankly, Miss Marsh, the evidence is, it's overwhelming. Nurse Elaine Marsh looked at the folder. She looked at the printed logs. She looked at the face of every person standing in that hallway, the wide eyes of her colleagues, the pale expression of the young resident who'd worked beside her for 6 months, the security guard who'd never once needed to look at her this way before. And then she did something that nobody in that hallway would ever forget for the rest of their careers. She smiled. Not a smug smile. Not a scared one. Not the smile of someone who'd been caught. It was something quieter than that. Something older. The kind of smile that belongs to a person who has seen far worse than this and has already calculated, in less than 3 seconds, exactly how it's going to end. She unclipped her badge, set it gently on the nurse's station counter, and said just 4 words. Elaine Marsh, you should wait outside. Nobody moved. Nobody spoke. And nobody, not Rourke, not Callahan, not the men with the clipboards, could explain why those 4 words made every single one of them feel, just for a moment, like they were the ones being handled. Who was Elaine Marsh? And why wasn't she afraid? The agency called her a float nurse. That's what the paperwork said. Float nurse, meaning she was assigned to no specific ward, available wherever the hospital needed coverage, filling gaps like water finds its way into cracks. Hargrove Memorial was understaffed. Every hospital in the district was understaffed. 3 nurses out on maternity leave, 1 on FMLA, 1 who'd simply not come back after the incident in January that nobody talked about out loud, but everyone still whispered about in the break room. They needed warm bodies with licenses. They needed warm bodies fast. What they got was Elaine Marsh. She arrived at 6:47 a.m., 13 minutes before her shift. The charge nurse that morning was a woman named Sandra Kowalski, 22 years on the floor, built like a piece of furniture no one had ever tried to move. Sandra looked Elaine up and down with the careful, practiced eye of someone who could assess a person's competence from posture alone. Sandra Kowalski. Float. Great. You'll be on Ward C, ICU adjacent. We're running 2 patients post-surgical, 1 sepsis case that's been touch and go since Tuesday. You comfortable with vents? Most float nurses hesitated at the word vents. Most float nurses asked follow-up questions. Most float nurses looked mildly terrified at the idea of an ICU-adjacent assignment on their first day at an unfamiliar hospital. Elaine said, Elaine Marsh, what's the PEEP setting on the sepsis patient? Sandra blinked. 5. And Elaine nodded like she'd already been thinking the same thing and went to find the supply cart. It was the first unusual moment. Nobody caught it at the time. The second came 2 days later. A pediatric patient, A 7-year-old named Marco who'd been admitted for a respiratory infection began deteriorating faster than his chart suggested he should. His oxygen sat dropped during the night shift. The on-call resident was new, panicked, and doing what new panicked residents do. Too many interventions, none of them quite in the right order. Elaine was walking past a room on her way to another patient when she stopped. Just stopped. In the middle of the hallway. Turned her head. Listened to the sound of Marco's monitor through the slightly open door. And then she walked in without being asked, without being summoned, without a word of explanation to the 2 other staff in the room. She recalibrated the oxygen delivery. Repositioned the child. A specific lateral tilt that the resident hadn't considered. She didn't explain. She didn't ask permission. She just did it. The way you do things when the knowledge in your hands is faster than the words in your mouth. Marco stabilized in 4 minutes. The resident stood there feeling like he'd just watched someone parallel park a spaceship. But beyond the clinical skills, there were other things. Smaller things. The way she carried herself. Spine completely straight, shoulders perfectly level, even after 12-hour shifts. The way she observed rooms before she entered them, a half-second pause at every threshold, eyes moving methodically left to right, top to bottom. The way she never took the elevator, always the stairs, always at exactly the same pace, never rushed, never slow. The way she drank her coffee black and heated to exactly the same temperature every single morning, set her cup down in exactly the same spot on the break room table, and sat with her back never facing the door. Her hands, when she thought no one was watching, sometimes moved in patterns. Not nervous habits. Not fidgeting. Something more deliberate. Like muscle memory for something you hadn't done in a while, but your body hadn't forgotten. Nobody asked her where she'd worked before. Float nurses came and went. You didn't interrogate the hired help. You just needed them functional and licensed. And Elaine Marsh was both of those things, and then some. What she wasn't was an open book. Her personnel file, filed by the agency, listed her previous employment as various government contract medical positions, references upon request. Her emergency contact was listed as a federal P.O. box in Virginia. Her certifications were extensive, and 2 of them were in classifications that the HR administrator, a man named Phil who'd worked there for 11 years, had simply never seen before and had to look up online. What he found gave him pause. Then he filed it under miscellaneous and moved on to the next stack of papers. The woman who'd arrived as a gap filler was already quietly holding the entire floor together. But no one was watching closely enough to understand why that made her dangerous to the wrong kind of people. Hargrove Memorial Hospital. 300 beds. 1 underfunded ICU. Several overlapping kingdoms of pride. Every hospital has a social architecture. Invisible lines of rank and power that have nothing to do with the organizational chart and everything to do with who has been there the longest, who controls the narrative, and who makes life difficult for those who don't fit the culture. At Hargrove, the king of that invisible architecture was Dr. Leonard Gauss. Gauss was the director of pharmacy services, a title that sounds administrative until you understand that in a hospital, the person who controls medications controls everything. Every prescription, every dosage, every dispensary log. He'd held the position for 16 years, and in that time had cultivated a network of dependencies that kept him untouchable. He wore his gray hair swept back with gel. He smelled like expensive cologne in an environment that smelled like nothing else but bleach. And he had a way of looking at nurses, particularly the female ones, that was not overtly inappropriate, but was precisely calculated to remind them that they were, in his estimation, delivery mechanisms for his decisions. He noticed Elaine Marsh on her 3rd day. Dr. Gauss, you're the float? From the agency? Marsh, is it? Let me be clear about how things work here. Ward C medication requests go through my office. Nothing gets pulled from the controlled substance cabinet without my countersignature. We've had discrepancies before. I don't want discrepancies. Elaine Marsh. Understood. Is the process different from the state dispensary protocol? He paused. Most new nurses didn't know there was a state dispensary protocol, let alone invoke it in a casual corridor conversation. Dr. Gauss, here we follow my protocol. Any questions, you come to me first. She held his gaze for 2 seconds longer than was comfortable. Then she nodded and walked away. And he stood in the corridor for a moment that had no clear reason to be as long as it was. He didn't like her. He couldn't have explained exactly why. But the feeling was immediate, and it was absolute. The second friction came from closer to home. A senior nurse named Patricia, 12 years at Hargrove, self-appointed cultural guardian of Ward C, took an immediate dislike to Elaine that was partly territorial and partly something else. Patricia's nickname on the floor was the Gatekeeper. She decided which float nurses got the easy assignments and which got the impossible ones. She distributed the workload not according to need, but according to loyalty. She had a circle, and if you weren't in it, you were outside it, and outside was cold. On day 4, Patricia assigned Elaine 4 patients simultaneously, including the sepsis case, a post-operative bowel resection, and 2 patients awaiting discharge whose paperwork was deliberately left incomplete. It was a punishing load designed to overwhelm and humiliate a new nurse into submission. Elaine completed every task, on time, without complaint, without asking anyone for help, though twice she quietly and specifically helped other nurses with their tasks in the spaces between her own. That made Patricia angrier, not less. The young resident, Dr. Okafor, the one who'd watched Elaine stabilize Marco, tried to befriend her. He'd bring her coffee during the night shifts. He'd ask questions, not flirtatious ones, genuine clinical questions, because he'd realized quickly that whatever she knew, it was worth knowing. Dr. Okafor, where'd you train? Seriously, you handled that Brady last week like you've done it 100 times in a field with no equipment. She smiled. The particular smile that didn't answer the question, but somehow made you feel you'd been given something anyway. Elaine Marsh. I've worked in a lot of different environments. Some of them had less equipment than this. Most of them had more at stake. He'd wanted to ask more. She was already walking away. Then there was Administrator Rourke, the man who would later hold the folder with her name on it. He was a compliance officer at heart, a numbers man, a man whose understanding of medicine was purely operational. Patients were bed days. Nurses were labor costs. Medications were budget line items. He had never once set foot on a ward floor after 5 p.m. He made decisions from spreadsheets. He'd noticed the controlled substance logs flagging over the past 3 weeks, numbers that didn't line up. And when the inventory team traced the discrepancies to access logs, Ward C, night shift, repeated entries, all under the same badge number, his response was swift, certain, and completely wrong. He didn't investigate. He didn't verify. He built a case from the data he had and filled in the story around it with the most convenient narrative. Convenient narratives are almost always wrong, but they're almost always believed. Elaine Marsh was being built into a villain by people who hadn't stopped to ask a single question, and the stage was being set for a confrontation that none of them were prepared for. The first anomaly, in retrospect, was the night of February 14th. Valentine's Day, which matters only because the ward was short-staffed due to call-outs, and because the pharmacy automated dispensing machine logged 3 access events between 2 a.m. and 3 a.m. under Elaine's badge code. All 3 for controlled substances. All 3 for patients whose charts, reviewed in daylight, showed no record of medication administration during those hours. Nobody flagged it immediately. It was one nurse, one night, during a period of chaos. These things happened. But then it happened again. And again. Same pattern. Same hours. Same badge. What nobody looked at, because nobody thought to look, was the surveillance footage for the pharmacy corridor. Not the footage from inside the pharmacy. The footage from the hallway that showed who walked past the dispensary machine between 2 and 3 a.m. Because on every single one of those flagged nights, Elaine Marsh was visibly, demonstrably, on the other side of the building, sitting at the Ward C nurse's station, charting, visible on 3 separate cameras simultaneously. A woman cannot be in 2 places at once. But the badge log said otherwise. Someone had her badge code, and they were using it very carefully. But that discovery was 6 weeks away. In the meantime, Elaine Marsh kept working, and kept noticing things that no one else noticed. The second anomaly, in week 3, a patient named Gerald Hutchins, 68 years old, recovering from cardiac bypass, stable by all metrics, began showing subtle signs of opioid toxicity that his attending had missed. His pupils, his respiratory rate, the particular shallow quality of his breathing. Elaine saw it during a routine vitals check, not his primary nurse's responsibility, not her patient, just a man in a bed she walked past twice an evening. She documented her observations, flagged them formally, and then did something that nurses are not technically supposed to do without a physician's order. She reduced the continuous pain infusion rate by the minimum measurable increment. A change so small it was barely a change, but just enough to begin reversing the slow accumulation of drug in his system. Patricia, you touched his PCA pump. Without authorization. I'm writing this up, Marsh. That's a protocol violation. That's Elaine Marsh. Check his CO2. Transcutaneous. Do it in the next 10 minutes, or you won't need to write anything up. You'll be calling a code. Patricia checked. The number was alarming. Hutchins was, in clinical language, heading toward respiratory depression. What Elaine had done, The tiny adjustment that had no business being made by a float nurse had almost certainly bought him 6 hours and the chance for a physician to intervene correctly. Patricia didn't write it up. She didn't thank Elaine either. She walked to the break room and sat very still for 7 minutes. The third anomaly was subtler still. Dr. Gauss began showing up on Ward C at unusual hours. Not during medication rounds. Not for clinical reasons. He'd appear in the corridor, briefly, purposefully, check something on the dispensary terminal, and leave. He never spoke to Elaine directly after that first day, but she noticed the appearances, and she noted something in the timing of them. They always came within 40 minutes of the overnight pharmacy access events logged under her badge. She began keeping her own notes. Not on hospital systems. On paper. In handwriting so small and so compressed it looked, to anyone who glanced at it, like she was doing crossword puzzles in the corner of the break room. She was not doing crossword puzzles. She was building a map. And she was doing it with the quiet, systematic patience of someone who had been trained to see patterns in noise, in environments where missing a pattern meant something far worse than a bad performance review. Dr. Okafor caught her once. 3:30 in the morning. Break room empty. She had her small notebook open and she was drawing something. A timeline, he realized, with names and times, and what looked like pharmacy cabinet numbers connected by thin, precise lines. Dr. Okafor. Elaine, what is that? She closed the notebook. Looked at him. That 2-second look that always landed somewhere between assessment and decision. Elaine Marsh. A crossword. Go back to bed, Okafor. You have rounds in 2 hours. He didn't go back to bed. But he didn't push either. He sat across from her with his coffee, and they existed in the quiet of the empty break room. Two people who both knew, for different reasons and from different angles, that something was very wrong in this building. The week before the arrest, Sandra Kowalski, who was not a woman prone to sentiment or intuition, stopped Elaine in the hallway and spoke to her quietly, out of earshot of everyone else. Sandra Kowalski, I don't know what you're mixed up in, but Rourke has been in the compliance office every day this week. And every time I walk past, your name is on the whiteboard. You need to watch yourself, Marsh. Elaine looked at Sandra for a moment. And then, only for a moment, something shifted in her face. Not fear. Not even concern, exactly. More like the particular expression of a chess player who has just been told that the opponent is about to make a move she's been waiting for. Elaine Marsh. Thank you, Sandra. That's actually very helpful timing. 3 days later, the men came down the corridor, and Elaine Marsh was already standing at the end of it, waiting. The confrontation in the corridor had just reached its peak. Rourke with his folder, Dr. Callahan with his disappointment, Elaine with her inexplicable 4 words, when the crisis inside Ward C began. It started with an alarm. Not unusual in a hospital. Alarms are the ambient language of healthcare. But this one was different in pitch and in pattern. Not the single beep of a monitor needing attention, but the cascading overlap of 3 alarms firing simultaneously from the same room. Room 412. Gerald Hutchins, the cardiac bypass patient Elaine had quietly protected 2 weeks before. He was crashing. Not slowly. Not gradually. He was crashing the way patients crash when something has been building invisibly for days, and then every compensating mechanism fails at once. The on-call physician that morning was a hospitalist named Dr. Brennan, brand new to Hargrove, transferred from a community hospital upstate where the most critical case of his month was a complicated UTI. He arrived at room 412 at a run and immediately began doing what frightened doctors do. He started giving orders. Fast, overlapping, slightly contradictory orders that the bedside nurses tried to follow while simultaneously managing the chaos of a man whose blood pressure was reading 68/40 and whose heart rhythm on the monitor looked like a seismograph during an earthquake. Rourke watched from the corridor. He looked at Elaine. He looked at room 412. He looked at the folder in his hand. Rourke, this doesn't change what's happening here, Marsh. When that's dealt with, we continue this conversation. She wasn't listening to him. She was listening to the monitor. She was watching the bedside nurse's hands. She was watching Dr. Brennan's face, the particular expression of a person who has reached the outer edge of their competence and knows it, but can't stop moving long enough to admit it. The crash cart arrived. A respiratory therapist appeared. Dr. Okafor came in from the stairwell at a run. The room was full of people and loud and urgent and wrong. All of the energy and none of the precision. Hutchins went into V-fib. The monitor screamed the particular tone that is not an alarm but a notification, the clinical equivalent of a white flag. Cardiac arrest. A man's heart had stopped. And in room 412, 7 healthcare professionals were moving in 7 different directions, with no clear center of gravity. Dr. Brennan began chest compressions. That part was right. But his hands were wrong. Too far up on the sternum, a common error under stress, and his rate was too fast, driven by adrenaline, not by training. Patricia was at the medication drawer pulling epinephrine. She was shaking. The nurse at the defibrillator, young, second year, this was the first code she'd run, was asking Dr. Brennan for confirmation on the energy level, and he was already mid-compression and couldn't answer, and she was frozen waiting for confirmation that wasn't coming. This is the moment. The real one. Not the accusation in the corridor. Not the folder with Elaine's name. This is the moment that defines everything that comes after. Elaine Marsh walked through the door of room 412. She did not run. She did not announce herself. She moved the way water moves, directly, without wasted effort, filling exactly the space that needed to be filled. She stepped to Dr. Brennan's side, placed one hand on his shoulder, not grabbing, not pulling, just a single firm contact, and said one word at precisely the volume and tone that cut through every alarm and every voice in the room. Elaine Marsh. Switch. He switched. Without arguing. Something in her voice had bypassed his ego entirely and spoken directly to whatever part of him knew better. She took over compressions. Hands in exactly the right place. Rate exactly right. 100 per minute. Metronome perfect. Depth exactly right. Full recoil between each compression. Every element precise in a way that came not from a recent training refresher, but from somewhere much deeper. Elaine Marsh. Charge to 200. Don't wait for me to stop. AP 1 milligram for push, now. Okafor, airway, jaw thrust, two-person bag mask. You're going to need to reposition. His neck is extended too far. Patricia, I need another large bore 4 access, left antecubital. Tell me the last potassium level. The room recalibrated around her. Not because she was the highest-ranking person in it. She wasn't. She was a float nurse. She was, technically, suspended. She was in the middle of being arrested for theft. None of that mattered, because in room 412 in that moment, the only thing that mattered was competence, and competence has a sound that living things recognize instinctively. Everyone in that room heard it, and everyone moved accordingly. The defibrillator charged. She called clear with a single hand gesture, swept the room without breaking compression rhythm, and then stepped back for precisely the interval the shock required. The charge fired. Hutchins's body moved. The monitor held its breath. Sinus rhythm. Weak, but sinus rhythm. The cardiac mountain had not been climbed yet, but they had stopped falling. Elaine resumed compressions. One more cycle. And when the rhythm held, she stepped back, called the medication sequence to Patricia, and began directing the stabilization with the quiet, systematic authority of someone running a procedure they've run before. Many times before. In conditions considerably worse than a hospital room with working equipment and 4 additional staff members. Dr. Brennan stood at the foot of the bed watching a float nurse run a code more cleanly than anyone he'd seen in 15 years of practice. His folder was gone. His authority was somewhere on the floor. He wasn't angry. He was transfixed. Dr. Okafor was crying. Not dramatically, just the particular quiet release of someone who has watched something happen that they know they will tell their children about someday. Rourke stood in the doorway of room 412. He still had the folder. His hand had gone slack around it, and it was bending under its own weight. He looked at the woman running the resuscitation, and something in his expression shifted, not guilt yet, not understanding yet, just the very first tremor of doubt that would eventually bring the whole constructed story down. Gerald Hutchins had a pulse. It was going to hold. And in the hallway outside Ward C, the elevator opened. 4 people stepped out. 2 in military service uniforms. 1 in a federal inspector's blazer. 1 in civilian clothes carrying a laptop and a very specific kind of case that law enforcement personnel carry when they expect to conduct a forensic audit of electronic systems. They had not been called by Rourke. They had not been called by Callahan. The badges they produced at the nurse's station were not hospital badges. They were federal. And the one in civilian clothes, a woman in her 40s with the bearing of someone accustomed to walking into rooms that weren't expecting her, asked the receptionist 3 words. Is she here? The woman in civilian clothes, she introduced herself only as Special Agent Harmon, Defense Criminal Investigative Service, did not go to the administrator's office. She did not check in with Human Resources. She walked directly to Ward C with her team and asked the nurse's station receptionist to tell her where Elaine Marsh was. Rourke appeared from room 412. He was still holding the folder, though something in his grip had fundamentally changed. Rourke, can I help you? I'm the compliance administrator, and if this is regarding Nurse Marsh, I need to inform you that we already have. Special Agent Harmon. Mr. Rourke, I know who you are. I've read your incident report. I'm going to ask you to hold that folder and not act on it until we've completed our review. Are we clear? He opened his mouth, closed it. He'd never had someone speak to him that way in this building before. The two military personnel had moved to either side of the hallway with a practiced quietness that made the corridor feel smaller. Elaine emerged from room 412. She looked at Harmon. A long look. A recognition look. Special Agent Harmon. Chief Warrant Officer Marsh. You look terrible. Elaine Marsh. 41 hours. You could have come yesterday. Special Agent Harmon. We needed the full picture. We have it now. The silence in the corridor lasted approximately 4 seconds. In those 4 seconds, every person who had been standing there, Rourke, Dr. Callahan, Patricia, the two security guards, Dr. Okafor, Sandra Kowalski, processed the words Chief Warrant Officer and arrived, at different speeds, at the same destination. This woman was not a float nurse. She had never been a float nurse. Elaine Marsh, full name Elaine Marsh Caldwell, was a Chief Warrant Officer, Grade 4, United States Army Medical Corps. She had served 21 years, 3 combat deployments, a decade of special operations medical support, which is a phrase that means she had kept people alive in environments where the difference between life and death was measured in seconds, and the nearest hospital was sometimes 3 days away by helicopter if the weather cooperated. She had been decorated, multiple times, awards that are given quietly, not publicly. Her service record included a commendation from a 4-star general. It also included, buried in the middle section, a detailed account of a particular operation in which she had single-handedly managed a mass casualty event with 2 medics, 1 4-bag, and a med kit that was, to use the exact language of the commendation, grossly insufficient for the scale of the situation. She had not come to Hargrove Memorial as a float nurse by accident. She had been placed here, by request, by federal contract, because the Defense Criminal Investigative Service had received a tip, sourced from a routine pharmaceutical DEA audit, that a controlled substance diversion scheme had been running through Hargrove for 14 months. Opioids being redirected, quantities significant enough to constitute a federal felony, and the person running it was careful, systematic, and had sufficient authority to cover their tracks. Harmon's team opened the laptop. The forensic audit had taken 2 days of remote work and 3 hours of on-site access that morning before anyone arrived on Ward C. The access logs that had been used to frame Elaine Marsh were not genuine access logs. They were altered, specifically altered, within the hospital's electronic medication management system to replace the true badge code with hers. The originals, the real access events, traced to a different badge entirely. Dr. Gauss's badge. 14 months of controlled substance diversion. Fentanyl, morphine, oxycodone, redirected from patient care, falsified in the dispensary records, and diverted through a purchasing broker who had no connection to the hospital on any visible document. The scheme was sophisticated. It had worked because Gauss had authority over the very systems used to audit it. Until Elaine started noticing the timing of his corridor appearances. Until she started mapping the access events against the pharmacy logs in a small notebook in a language of connecting lines that looked, to the uninitiated, like a crossword puzzle. Dr. Okafor said, very quietly, "Dr. Okafor, you knew. You knew the whole time. That's what the notebook was." Elaine Marsh. I had a working hypothesis. The audit team had the tools to prove it. I just needed to stay in place long enough for them to finish. Dr. Okafor. While they were building a case against you. Elaine Marsh. That's the risk of the position. You let the pressure build. You don't move too early. And you trust that the right people are doing their jobs on the other end. Rourke had set his folder down on the nurse's station counter. His hands were empty. Dr. Callahan was somewhere between mortified and devastated. Patricia was crying, though she would later insist she wasn't. Sandra Kowalski had her arms folded and the expression of a woman who had been right about something important and had known it for weeks without being able to name exactly what it was. Down the hall, 2 federal agents walked into the pharmacy office. Dr. Leonard Gauss had not yet arrived for his shift, but his office was already open, and everything inside it, the files, the system terminal, the small external drive that was plugged into the back of his desktop computer, was exactly where Elaine's map said it would be. Dr. Gauss arrived at 9:47 a.m. to find 2 federal agents, a military auditor, and a forensic IT specialist occupying his office. He turned around in the pharmacy entrance and walked back toward the elevator at a pace that might have looked calm to someone who didn't know what they were watching. He was detained in the parking structure, quietly, without incident. The way things end when everyone has done their job correctly. Back on Ward C, Elaine Marsh accepted her badge back from the nurse's station counter where Rourke had set it. She clipped it back on. Then she picked up a patient chart. Ward C still had patients. Gerald Hutchie,